how they go together in some regards, and how COVID plays a part with the heart and cardiac care, and also what we've done here at UW to kind of adjust our practices to fit in with this pandemic. So again, here we go, our objectives: describe the process for STEMI throughout the continuum of care, verbalize time-sensitive treatments in the care of a STEMI patient, verbalize nursing and EMS roles in caring for the STEMI patient. We're going to talk about ways that COVID-19 affects the heart, and then ways that we've adapted our protocols to protect STEMI patients, cath lab staff, and other EMS staff, hospital staff. So just some quick statistics to start out. Every 40 seconds, an American will have a heart attack. And when we look at heart disease, and this is including coronary heart disease and hypertension and stroke, it remains to be the #1 cause of death in the United States. Coronary heart disease contributed to 13% of deaths in the U.S. in 2017, causing 365,914 deaths. So data from 2005 to 14 estimated that the annual incidence of heart attacks in the U.S. was 605,000 new ones and 200,000 recurrent, which that was kind of interesting to me, seeing that about 1/3 of the people had recurrent heart attacks. From 2007 to 2017, the annual death rate attributable to coronary heart disease has declined 28.1%, and the actual number of deaths declined 10%, but the burden and risk factors remain alarmingly high. So that kind of shows that, because of our systems of care that we put into place, some of the new medications, all of the advances that we're making in the medical world and pre-hospital care and working together as a collaborative team is making an impact, but it shows that we still have more work to do. So what is a STEMI? So STEMI is a clinical syndrome. I'm just going to read this word for word off the slide. I do this. Defined by characteristic symptoms of myocardial ischemia in association with persistent ECG, ST elevation, and subsequent release of biomarkers of myocardial necrosis. So I read this word for word because this comes from the American College of Cardiology. This is the classic definition of a STEMI, okay? So the one thing I kind of want to point out when we read this is ST elevation and subsequent release of biomarkers of myocardial necrosis, okay? So we talk about ST elevation for many different reasons, but until we see that release of biomarkers, which is most accurately or specifically with like the troponin, that's how we can actually verify that the patient's having a heart attack. Of course, when we talk about STEMI patients, we don't wait for that biomarker to come back, but that really truly does fit the criteria for a STEMI. So why is the ST segment so important? So the ST segment is, it represents a section between the complexes in which the ventricles are depolarized and repolarized. Okay, so you can see that ST segment. Let me grab my little pointer here, right here. Okay, and this is the key indicator as to whether the patient may be experiencing an ischemic insult or injury to the myocardium. So when we see, if you look at this right here, we call this the J point, and we look straight across here, it should be nice and flat, right? Okay, so if we see it go up, and we'll talk about how much it has to go up to be considered a STEMI, then we're thinking this could be a STEMI. If it depresses, we're thinking about, okay, this patient may be having ischemia. So STEMI criteria, we do have very specific criteria that we're looking at. ST elevation at the J point, and I showed you that on the last slide, and at least 2 contiguous leads, meaning 2 leads that are looking at the same portion of the heart. So for men, we're looking at greater or equal to 2 millimeters, or women 1.5 to 2 or 1.5 in leads V2 and V3. And then we look at greater than 1 millimeter in other contiguous leads or limb leads. If we see ST depression in V1 through 3 without ST elevation in other leads, this may indicate a posterior myocardial infarction, and it's a little bit more of an advanced concept, but we don't have leads on the back, and so on the patient's back, so this view is taking it from the opposite side, so that's why we would see depression in those leads. So what causes a STEMI? So when we say STEMI, ST meaning ST segment, and then E meaning elevation, and then MI, myocardial infarction, meaning a heart attack. All right, so they're basically associated with the buildup of plaque, which ruptures in the coronary arteries. So what happens is you may have a plaque that's kind of underlying under the surface of the vessel in the normal artery. So it may be building up in there. What happens over time, you might get inflammation in that vessel for various reasons. We know diabetes, smoking, high blood pressure, etc. Causes the vessel walls to weaken. And what can happen is that plaque can rupture through. All right, so when that plaque ruptures through, that's built up of cholesterol and fatty materials, it's very sticky. So then what happens is the body has that natural mechanism that it wants to come and repair. And so what happens is platelets kind of get clumped, start to go into that area, and they get clumped up. So when you have platelets clumping up in the blood vessel, that blood vessel subsequently gets blocked off, okay? And so typically when we see STEMIs, a lot of times, not every time, but we do see a lot of times 100% occlusion from that blood clot. And so when we look at, you may have heard the term NSTEMI too. So NSTEMI meaning non-ST elevation myocardial infarction. So the patient may present maybe like a STEMI, chest pain, diaphoresis, nausea, other symptoms. But what happens is when we do the ECG, we don't see that ST elevation. We may see just all ST depression. We may see T-wave inversion. We may see different ischemia, but we don't see that ST elevation. So then there's different protocols for STEMI versus NSTEMI. And a lot of times when we see the NSTEMI, it's not necessarily that 100% thrombotic occlusion. So here's a cross-section of a cadaver for occluded artery. And so the NSTEMI, you see there would still be blood flow going through here, whereas the thrombotic burden in this vessel is quite high. So when we talk about symptoms of a heart attack, we hear, oh, sorry, my picture's over my slide, but we look at the pressure, squeezing, or fullness in the chest. And that's like the one that people say, oh, I feel like I have an elephant sitting on my chest. And so that's what the big one that people think of. But then we get people who sometimes, and I can't tell you how often I read a case, I review all STEMI cases that come into the hospital where people are saying, I feel like I had indigestion, GERD, and they're popping Tums and they're trying Maalox or whatever to try to get rid of that. And they don't necessarily right away attribute that to a heart attack. So I do see when I look at the symptoms of these patients quite a bit that epigastric pain. But also going along with that, we see nausea, shortness of breath, fatigue, jaw pain, back pain, all sorts of different symptoms that, some people might just dismiss as related to something else. So when we talk about women's symptoms, they a lot of times are the same, but they can have some nuances, some different things. So something that women may say over time is extreme fatigue, or things are getting to be more difficult over time that were once easy to them. So maybe they did a 2-3 mile walk a day, didn't have any problems with that. And all of a sudden over the last few months, that 2-3 mile walk is becoming a lot more difficult, or they can't even do it anymore. So they may experience that. Sometimes they have, what was I going to say about that? Sorry, I just lost my train of thought. But yes, so they do have that extreme fatigue where things are a lot more difficult to them. Those prodromal symptoms, we call them, leading up to the actual event. But they may not attribute it. And shortness of breath, I'm sorry, that's what I was thinking of too. I have read too where over time, shortness of breath for women seems to be one of those prodromal symptoms too. That walk, not only is it getting harder, but it's getting harder to breathe and that sort of thing while they're doing it.
The criteria were set out at a time when people were giving thrombolytic therapies. And this was kind of retrospectively studied in big trials that were done in the era of thrombolysis. And so the Gusto trials, this was looked at many years ago. And it seemed that the criteria was borne out. Those people who met those criteria and got thrombolytics did better with the thrombolytics. And that's kind of how the criteria came about. In practicality, it probably has to do with the degree of the chest size and the impedance that the chest wall provides, and you need to kind of overcome that with a higher amount with men versus women. So this is based on prior data from previous thrombolytic trials. So
on to time is muscle. So we've all heard that saying, time is muscle, meaning as soon as we want to make sure that we're getting the patient treated as quickly as possible, also kind of getting that education out there to patients that if you are having chest pain, don't ignore it. Even if it's not truly a heart attack, it's so important that you get help immediately, because as you can see in this grid, and I took this, I didn't quote it, but I kind of snipped it out from a AHA book because I really thought that the graphic was good. So I'm going to give them props for this picture. Is at the time of onset, if you're treated within 20 to 40 minutes, the likelihood of the extent of the infarction is about 0% of the wall. And then as you see, as time goes on, 30 minutes, 10, 1 hour, 30%, 250, 470, 690, 24 hours, or 100%. So that wall is damaged and likely, not to come back. So this just kind of highlights the importance of getting treatment and getting patients and expediting care as quickly as possible, because the longer you wait, the more damage it's done. And it doesn't doesn't happen over a period of days. It's really a matter of hours. And then going on to the history, I thought this was an interesting slide, looking at the history of modern medicine and the ECG machine, because this is really how we are able to recognize and treat patients so quickly. Looking at the first ECG machine, and you can see, I don't know how this man, he's obviously brilliant to come up with something like this. He's got his foot in water and arm in water and whatever. And so I just thought that was William Einthoven. And you might hear his name when we're talking about 12-lead ECGs and interpretation with that. But he was the first one who invented the first practical electrocardiogram and received a Nobel Prize for medicine. And as you can see, it has changed the trajectory for patients who are having heart problems and heart attacks. Looking at the now modern ECG, and I would say this is probably even looking a little old. I mean, they still look like this in the hospital, but I also wanted to show in clinics, you may see this kind of laptop setup. So now we can run them right through the laptops. And then looking at the defibrillators that EMS and other providers use out in the field, able to do so many things on these monitors and capture a 12-lead ECG and transmit it through the machine to the hospital. So all these advances that we've made over the years have really made a huge impact on how we're able to treat patients. So one of the questions I get asked is who should get an ECG? And per the American Heart Association, all patients with ACS symptoms, age 30 and older, patients with atypical symptoms, age 50 and older, and patients 80 or older with abdominal pain, nausea, or vomiting. Because any one of these things, as I talked about earlier, could mean the patient is having a heart attack. So just because a patient is 35 years old and comes in with chest pain and you think, well, he's too young to be having, or she's too young to be having a heart attack, not true. I mean, we know patients in their 20s have STEMIs, legitimate STEMIs. So we need to be looking at the patient as a whole and not the age, not, risk factors, because anybody can have a STEMI at any age. So, and then again, 80 or older with abdominal pain, nausea, or vomiting. The older you get, the older your arteries are, the more problems you might have. So looking at all those different symptoms, and it kind of goes back to the epigastric symptoms. So looking at an ECG, you look at the STEMI or the ECG, we're looking for STEMI criteria. And in this ECG, this shows inferior STEMI. So you can see the ST elevation in leads 2, leads 3, and leads AVF. So you can see here that this is an inferior STEMI. So we're looking at the leads that correspond to the certain area that they're looking at in the heart. With this one, we're looking at the anterior STEMI. So we've got the septal leads and the anterior leads, and you can see anteroseptal here. So this is pretty significant ST elevation. And then this one we just threw in here because we do see this occasionally. So if you get an ECG like this, and you're running a patient to wherever, coming from wherever to the hospital, and you see this, it's always a good thing to do instead of really kind of reading the doc in the box saying acute MI. We can't really tell from this ECG. So getting a new ECG and transmitting a new one would be the best course of action when you get something like this. There is challenges we realize with being on the road and transmitting while you're in motion. But again, trying to have the patient, and sometimes the patients can't stay still either, but this would not be a good ECG to diagnose a STEMI off of. So just quickly looking at the different areas of the heart and the territories the arteries cover. So looking at the right coronary arteries, if you look at this little teal shaded box here, 2, 3, and AVF. So you can see here it goes down and around underneath the heart inferior. Looking at the light blue here, we have the circumflex, or no, I'm sorry, the septal. And so you have, or anterior right here, anterior, V3 and V4. And then where's the lateral? So the green wall here, lateral. So that would be 1, AVL, V5 and V6 in the green color. And then we have the septals right here. So those are the septal perforators, which is that dark blue. Okay, and those are what the areas that lead to that, correspond to that area of the heart. So when we see those leads and we see the changes in those leads, we can kind of start to prepare. Oh yeah, okay, so knowing that they had, 2, 3 and AVF, this patient may be high risk for arrhythmias. We can start prepping, pulling the correct equipment before the patient even gets there under the suspicion that it's the ECG, what they tell us. So we talk about reciprocal changes. Basically, leads opposite of the injured area show ST depression because they're viewing the MI from opposite angles. So when we look at the inferior 2, 3 and AVF, we're looking at the V leads. Lateral would be 2, 3 and AVF. RV, we don't have any. Anterior, V1 through V4, which is 2, 3 and AVF, is the reciprocals. And then the posterior wall, this is where we talk about putting the leads. If you wanted to do that, you could put them on the back of the patient. So I'm always asked about right-sided ECGs and what do you think about doing those? Okay, so quickly, what about them? They are help diagnose RV myocardial infarction. They're placed in the mirror image on the right side of the chest as compared to the left. So taking those leads, moving them to the right. Elevation on the right side leads, you can suspect a RV or a right-sided infarct. And if you wanted to, you could take V4 and put it over, and that's going to be the most sensitive and specific lead with the best view of the RV. So we talk about those, and here's kind of what we're looking at if you were going to do that, moving everything over. And here you can see here the V4R, and that's, you would want to definitely label that if you were to run one of those. Okay, that this is a right-sided ECG, so you can tell the difference. So one of the things we talk about is if you have a patient with ST elevation in the inferior leads and you feel that it's definitely a STEMI, we want you to just kind of get moving to the hospital. We don't really want to stay on scene to be doing a right-sided ECG because that patient's going to go to the cath lab regardless. And so that is something we don't want to delay transport to do. Now, if you're en route and you want to do it and you feel like it's necessary, if you want to try to give some sort of nitrates or whatever it is to confirm, then go ahead and do it, but we do not recommend delaying to perform one. Posterior MI, kind of the same situation, it's kind of these more fancy type ECGs, and they too are associated with the inferior wall, right, RV infarcts, and then with normal placement, we talked about this earlier, it'll look like ST depression in V1 and V2. And you can see here, this is how you would place them. So you take V5, V6, 5, 4, and then connect 9, 8, and 7 on the back. And again, when you run one of these, making sure that you're clearly labeling that it's a posterior ECG on that document. And again, we don't want to delay transport for this one either. So if you feel like you have a patient that you see the inferior STEMI, then you want to go ahead and just get them to the hospital. Okay, quickly, what about MONA? So we talked about this for years. We've heard MONA, morphine, oxygen, nitro, aspirin. Those are the things that we used to give STEMI patients or heart attack or heart patients really quite routinely, ACS. So morphine, there has been some evidence to suggest it can actually extend the infarct and also decrease the absorption of the P2Y12. Like the antiplatelet drugs. So we try to use narcotics very judiciously, but it also has a good place if the patient's real anxious and having a hard time breathing and kind of calms them down to help with the perfusion and their afterload and calm them down a little bit. So there is a place for it, but if you do have to use it very sparingly. Oxygen, again, we don't need to be putting oxygen on every chest pain patient. So we say if the stat's about 93 or below, then you want to put the oxygen on and just use it enough to titrate so they're 93 or above. That can also further extend the infarct. Nitroglycerin, that does have a place, and we still do use that. But again, using that sparingly with patients who may have hypotension, RV infarcts, and then because that certainly can decrease the preload. And then also excuse me, if they've had any ED drugs, erectile dysfunction drugs, you want to assess that too, because that can be a dangerous drop in blood pressure. So just be looking at that. And then aspirin, that is absolutely, if they don't have a contraindication to aspirin, you want to be administering that if it's part of your protocols to do so, because this is the one thing that can really, of all these things, make a difference in terms of it's not going to save their life, but it does help in that regard with the platelet inhibition. So other medications you may see, the heparin 60 units per kilo up to 4,000. And then we're looking at the P2Y12 inhibitors of ticagrelor, which is our preferred one now. But Plavix is still completely acceptable if you don't carry Brilinta. And then we really don't see prasugrel that much anymore. And then when we talk about complications from STEMI, so untreated STEMIs that go on for a few days or not even, if they have major damage to the heart, we do see some of these issues where you'll see a ventricular septal defect, papillary muscle ruptures, which hold the valves. So those would, if they rupture, that valve's flailing. So cardiac free wall rupture, they may get holes in their hearts, aneurysms, LV outflow tract obstruction, or LV or RV failure with cardiogenic shock. So, people might not die from heart attacks. They might live. They might make it through that 24-hour, 48-hour week. They might come in a week later, but it doesn't mean that they're going to live a good quality life. And that also goes along with, the statistics we get. It's not necessarily true they could be living disabled due to some of these variety of these things. So again, we do have guidelines for transfer that you may see in your regs or at your referring facility. And so this is just a little worksheet to help you that was developed years ago and to help kind of keep track of our protocols, and it kind of lists everything there for you. So it lists the line for the access center at UW and St. Mary's. So if you choose to go to either place, that's right there for you, and kind of we have the same protocols as them, which is really great. So you don't have to wonder, if I'm taking them here, what do I need? We've agreed on that, and that's been in a long-standing. We have a good relationship for years. So this is a good worksheet for you. If you don't have them, you can let me know, and my contact information is at the end of the slide, and I will get you a copy of that. And then when we're transferring patients, we want to make sure that patients in the ER are placed on STEMI alert, the ER that is placed on a STEMI alert when the patient's coming. Cath lab makes a room available or the call team's activated. The ICU makes sure the bed is ready for the patient, and then med flight will be activated if needed. And we're just going to kind of speed through this a little faster so I can get Dr. Raval up here, but looking at transport to a PCI capable facility, first medical contact to device is 90 minutes. So first medical contact can mean when the patient walks in our front door at University Hospital, or first medical contact can mean being picked up in the field 20 miles away. So there is a little bit of a discrepancy there, but 90 minutes. Then when we're looking at transport from a referring facility, we have 120 minutes. Okay, so from when they reach the door. So if they're coming from a referring hospital, from the minute they walk in the door there till we open that vessel, 120 minutes. So that's why it's really important to move quickly. Once you get that ECG, in 10 minutes within walking in the door, letting UH know, or same thing on scene, letting us know immediately. And then that's the big thing, is transmit the ECG again as soon as you can. Let us know. Follow up with a detailed radio report regarding the patient condition if you're coming from the field. That is a great way to really ensure the patient's going to go directly to the cath lab if the team is ready and the room is available. Some of the unavoidable delays to the cath lab. So if the patient has a compromised airway, they're going to have to stop in the ED. We want to make sure that the patient, if they had a cardiac arrest and we don't know if they hit their head, it was unwitnessed, we want to make sure that we're getting a CAT scan to see if they have any head bleed or any kind of hemorrhage going on there. If there's any thought they might have active bleeding, if they said they've had bloody stools or we have evidence of that or something, we're going to make sure that we kind of rule that out before we take them up to the cath lab and give them a lot of blood thinners. DNR status, if they're a DNR, doesn't mean they're not going to go to the cath lab, but we need to have a well thought out conversation with that patient and or their family. If the ECG does not meet STEMI criteria, we will have them stop in the ED. System factors, sometimes with the weather, the cath lab staff may be driving in, and if they're not there, they can't go to the cath lab. Sometimes the cath lab we're very busy, so they could be everybody on the table. There's somebody on the table in every room, so you have to do a little shifting around. So if that's the case, we just have them pause for a minute while we get that situated. And I think we'll go through just looking at EMS barriers. You guys know sometimes not all EMSs have 12-lead ECG machines. We don't have the training, lack of transmission capabilities, and personnel. So those are some of the barriers we see. Fortunately, around here, we're very lucky, but in some of the more rural areas, we do hear that. And that's a very unfortunate thing. And then there's not always possible to get ALS or air transport to get a patient to the PCI centers. And of course, we have winter coming, so we see the snow. And then I also want to emphasize this too, safety first. And I found this infographic, and I think it's very interesting that we have to really take care of ourselves before we can I know everybody's so dedicated to patient care and wanting to do the right thing and get the patient there as quickly as possible, but the paramount thing and the most important thing is that the crew is safe and patient will get there when you can safely get there. So just making sure that, you know what, even though we're under all these time constraints, sometimes we get lost in that we all need to be careful. And that goes for the cath lab team who's driving in the middle of the night. So just want to emphasize that. Okay, and then the EMS responsibilities, once you get on scene, get that ECG within 10 minutes, transmit it immediately. Like I said, as soon as you know, cath lab team has a 30-minute response time. So they need to get, that's 30 minutes. So the longer you wait, there's another 30 minutes on top of that before the cath lab's even going to be able to get in on off hours. If the ECG doesn't meet criteria and the patient's having chest pain, any condition change, go ahead and repeat the ECG. You can always contact the cardiologist at UW for a consult also if this is a referring facility. If you are giving thrombolytics after a discussion, it's always good to collaborate with our doctors to talk about that. We try to aim for a door to needle, so when they hit your door till you give thrombolytics at 30 minutes. And then again, sending copies of all documentation from current ED visits and EMS documentation, all those pre-hospital strips, all that information is so important. If you can discontinue the drips, that'd be great. If they're on pressors or anything really life-sustaining, please, we don't want that. But anything that's not necessary, we don't need heparin drips. And then you just want to make sure that you're taking time to really explain to the patient what's happening because it's a very scary moment. So just getting in their faces, you know, and saying, yeah, we're taking care of you, we're moving fast, we're getting you to where you need to be, and then also explaining the family. And I do want to make a quick point about that with COVID. Families are not allowed, unfortunately, to come to the hospital. So if you could just let them know, either if you're sending them from a referring facility or picking them up, the patient up in the field, just taking the patient information, family information, and handing that off and instructing the patients. Unfortunately, University Hospital's policy during this pandemic is family members are unable to come, but we will give them the information and they will call you. And again, I will get you feedback in 24 to 48 hours if I can have the run report and the ECGs and all the documentation I need. So as soon as I get that, I start working on the reports and I'll turn that around. If I don't have that information, I'll do it as soon as I can get it. And when I give that report, those feedback reports back, I always think it's great if you could review that with your staff. And this just kind of highlights what our protocols, one of many. So many steps and so many players, including you guys in these protocols that it takes a village. It really does. And so looking at the chain of survival, early call, EMS evaluation, emergency department, and reperfusion therapy. Every link in this chain plays a role. And that's from, 911 dispatchers to the EMS to emergency providers to the cath lab to the floor staff to cardiac rehab thereafter. So with that being said, I want to say thank you because we have achieved the ACC Chest Pain MI Platinum Award for the 9th straight year and the AHA Mission Lifeline Gold Award, which are the highest achievement in both areas. And I want to thank you because you play a key role in that. And we cannot thank you enough for your partnership. And with that, I'm going to turn it over to Dr. Raval. Thank you.
I think everybody by now knows that we are in a worldwide pandemic, and they're probably sick of it. I know I am. This is the SARS-CoV-2 virus, sort of a representation of it. And it has multiple manifestations, but the patients that you'll see who have this, as you know, will have shortness of breath, cough, fever, sore throat, diarrheal symptoms, loss of sense of taste or smell. Sometimes they don't have any symptoms at all, which is a bit unnerving. And then when you look at this, from the time of onset of infection and as the days go on, the viral load starts off to be pretty high right at the beginning, or even just a few days before. And then it tapers off over the course of about 14 days. If people are going to develop symptoms with it, those mild to moderate symptoms tend to happen kind of early, day 2 to 4, 6, 8, and then they taper off. Those who are ultimately destined to have more severe illness will continue to have symptoms all the way out to 2 weeks, and then it'll start to dissipate. But sometimes it relapses. Now, when this is designed to be more about how does this relate to the heart? Well, most times in the hospital when we're seeing these types of people, because obviously the severe and critically ill patients are more in the hospital, we're seeing heart damage happen at this sort of stage. Does heart damage happen at the mild to moderate illness stage? Well, possibly and probably. There have been a couple of studies done in Germany looking at people who have had mild to moderate illness and have shown MRI evidence of inflammatory disease of the heart. Of course, that's being actively studied and concerned in particularly young athletes who already, carry a risk of sudden cardiac death, even with normal hearts. That does happen in young athletes who are at high performance. Does the coronavirus and subclinical, even with mild to moderate symptoms, does that myocarditis confer a worse outcome in those athletes or increase their risk? And that's a big dilemma, as you probably all know. The NCAA is looking at that very carefully, as are UW athletic programs. Our program here at UW has got an active study looking at UW athletes and doing MRI scans on them. Now, how does this relate to healthcare providers? So when we're talking about community spread, most times, most of the bulk of community spread is happening at this phase where the viral load is really high and people are transmitting it without even necessarily knowing it. Whereas in the hospital, when the viral load comes down, these patients are critically ill. So how does that jive? Well, the reason why this is because it's really the inflammatory phase that happens after the virus is hit, sort of the reaction to the virus that creates the so-called cytokine storm. And although the viral load is decreased, these are the type of people who are breathing hard, coughing a lot, and therefore, even though the viral load numbers are low, they're spreading, in particular to healthcare providers. So healthcare providers, particularly in emergency medical services, need to be aware that these patients can still spread this virus quite actively, even in these sorts of times. And the particularly high-risk periods are during bag mask ventilation, as well as at the time of intubation. So there's a lot of effort spent on protecting staff, and of course protecting patients, but protecting staff to prevent healthcare provider spread. So that's kind of how that works. Now we know that there are several high-risk people who are old and people who are obese. People who are smokers and have pre-existing heart disease are also at high risk, along with a number of individuals who understandably would be immunocompromised and have a worse outcome. Unfortunately, these are also the high-risk people that EMS providers see on a more routine basis. So you don't tend to see the young people. So you tend to see these people a lot more, and they're the highest risk patients of all. The heart-related manifestations of COVID relate to not just the effects of the direct virus on the heart itself, for example, viral particles in the heart muscle itself, which has been considered, but also probably more important, the systemic inflammatory response to the virus, our body's desire to target it. And that can lead to a variety of problems. It can lead to severe inflammation of the lining inside arteries, and as well as activation of a variety of cytokines, as well as complement factors. These are factors that can lead to thromboembolism, can lead to stroke, clotting, It could also lead to arrhythmias. It could also lead to indirect cardiac injury simply from the stress of the entire situation. But of course, it could also lead to myocardial infarction, which is why we're talking about this. So what happened with the coronavirus in the spring is, many centers, including ours, were kind of humming along with a number of patients who had heart attacks coming into hospital. And this is data from the Kaiser Permanente Hospital. And as the coronavirus numbers started to climb, patients hospitalized with COVID-19, there was a precipitous decline of people with acute MI. So where did all these heart attack patients go? This is in contrast to the previous year in 2019, where that number was, of course, relatively steady. And we saw that through the summer with about a 35% reduction in STEMI volume or STEMI type patients that came through. And part of the reason why that's likely to have happened is not because of some sort of protective event, of course. It's because patients were either too afraid to come in to see healthcare providers. So that's something you may see, as you are being called to evaluate them at their site. But also, they themselves, many patients did not want to impose a burden on the healthcare system, thinking that their, hospitalization is going to maybe prevent some COVID patient from coming in and so on. So there was this interesting psychology that was happening, and I happened to bear witness to both events happen directly with patients. But since that period of time, things have kind of reoriented, and now we're back, and the numbers are back up to kind of what we typically expect for heart attacks in general. Now, one of the things that we first measure in such patients who have COVID-19 is a troponin. Troponin is a contractile protein of the heart that's released at the time of heart stress. It's often associated with a myocardial infarction, abrupt closure of a coronary artery, but it can also be associated with kind of stress-related cardiomyopathy and an inflammatory myocarditis, or an inflammation of the heart itself. Both of these conditions are not associated with obstructive coronary artery disease, where, of course, myocardial infarction is. And if we look at the effect of troponin on overall prognosis, so this is a study out of China that looked at overall mortality in the early days of COVID. Now, this was in the early days of COVID, but nevertheless, in patients who had no pre-existing cardiovascular disease and had normal troponin, they had a baseline mortality of approximately 12% at 50 days, which is kind of high with COVID back then. But if they had a positive troponin without coronary artery disease or cardiovascular disease, their mortality climbed significantly, almost 7 times. And of course, when you had pre-existing cardiovascular disease and an elevated troponin, the mortality was a screaming high 70%, which is super high. Now, that was early on in the disease, where people didn't know what they were doing, really. Nobody knew. And since that period of time, with better supportive therapies, those numbers, mortality numbers, have declined indeed. But of course, there still is yet no cure for the COVID virus. When patients are being transported with suspected COVID, this is the kind of apparel that people are now becoming very familiar with. The mask, the patient wearing the mask, the N95 masks on key personnel, the gowns, the gloves, distancing amongst people that are not necessary, as well as these face shields. And actually some interesting data showing that these face shields that that we kind of have are actually quite beneficial to prevent in-hospital transmission amongst healthcare providers. And this are studies done between different floors that have been studied in Texas, as well as between different hospitals that had differing policies on the use of face shields. And now there's more evidence showing that these face shields do make a difference for healthcare providers. So to summarize, what do we do in our cath lab in the COVID era? And what we've evolved to is that if we have a suspected STEMI patient where the COVID status is unknown, and that's the majority of people, and they come into the hospital in the emergency department as a walk-in, they get initially kind of an initial verbal screen for COVID-related symptoms, a temperature check, There's a focus kind of history and physical related to COVID type symptoms and signs such as lung findings, as well as a history that suggests recent exposures and so on, pulse oximetry and chest x-ray, a bedside echo, and all of this is with the understanding that the cath lab is already being mobilized, to meet that. All of this can be done pretty quickly, and then of course a rapid COVID-19 test is performed. There's a lot of controversy on whether you need a bedside echo. In New York, when at the height of COVID, this was the initial required screen in order to make it into the cath lab, to ensure that patients had a regional wall motion defect to suggest a true myocardial infarction versus a global sort of overall heart function dysfunction, which would suggest more of a myocarditis, an inflammatory response of the heart. So that kind of thing is kind of done, but only sort of because we're waiting for the cath lab and are more out of interest at this point. In the cath lab, we have assigned a dedicated cath room in our center. It's F6369, that's the number. All of us use N95 mask shield for the staff, and until the COVID test comes back, we do arrange for ICU isolation, because oftentimes we're done with the procedure before the COVID-19 test comes back. But actually, frankly, lately, the test has been coming back much more quickly, so that's actually less of an issue. Now, what about field activation STEMIs? This is more pertinent to this group. We would like to know if the airway is stable, if the patient's awake and cooperative and hemodynamically stable. And if they are, then yeah, we would take them straight up into the cath lab, understanding we'll take them to our dedicated cath room with the appropriate apparel and plan for the ICU isolation until the COVID test. In this case, the COVID test is done soon after the procedure is finished. If they're not in airway stable, awake, and cooperative, we do not want to be in a position to be intubating patients with suspected where the COVID may be an issue in the cath lab. Just not quite designed for that. So for that kind of patient whose airway is unstable, they're not really awake or not cooperative, and they're unstable, we prefer to be evaluated first in the ED, kind of stabilize, have their airway dealt with, and then we'll be ready for them for the coronary angiogram. And this was just a nice case of a patient who, not really related to COVID, but more related to our overall STEMI process, who came through, was a real success, and just highlights the importance of how great a team we are and how great an environment we are to be working with EMS providers that do such great work. So, please.
I felt a little kind of burning in my chest, and I was belching quite a bit. I went in and looked at myself in the mirror and was a little bit ashy. Once I figured out that the color had gone out of me, I knew it was probably a heart attack, and I knew I wouldn't make it if I didn't get in there.
Bob did exactly the right thing. He recognized that something was terribly wrong. He arrived, and I remember this distinctly, he was being transported from his gurney onto our cath table, and his heart stopped. If that happened at home, that would have been a catastrophic problem.
They had to shock me back. So, it's pretty close.
Oh, he's got his
Fancy bandana on.
What a good boy, Jack. Oh, you're being so good.
What we're learning now is that patients have been so afraid of coming to the hospital for one of two reasons. One is that they are worried about contracting the coronavirus in healthcare institutions. The second reason is, frankly, they feel that they would impose a burden on the healthcare infrastructure. Really, it's important and incumbent upon patients who have the classical symptoms of heart attacks that is associated with heart attack to seek emergency healthcare right away.
I feel like I could do anything I did before I had it. I feel great. It's amazing. I'm sure glad it happened the way it happened and had the outcome it had.
You know, one of the things that I guess I can kind of make a commentary, and what Amy had mentioned earlier with family members, I think one of the sad realities, I mean, there's so many sad realities associated with COVID, it starts to make a list. But one of them is just the fact that patients' families aren't able to come through in and see their loved ones, which can be a really scary sort of thing. So any help that you can provide at the front end of just kind of explaining that that may be a possibility. Getting a phone number, because oftentimes at the end of a procedure we're scrambling, the patient's already received some sedation, can't really speak to them, is very helpful for us so that we can at least provide a prompt post-procedural kind of follow-up with the family, let them know how the patient's doing, and provide some reassurance.